Geneticist. So today we are going to be discussing an interesting and exploring topic of pediatric neurology, that is movement disorders. So we'll go with the basics of pediatric neurology and few basic concepts of movement disorders. And we'll also see a lot of videos today. I'm try to identify these videos. Once I play the video, I'll leave around 10 to 20 seconds time so that you can try and recognize the movement disorder, and then we'll discuss that later on. And we'll also touch few basics about the treatment aspects and also surgical options in movement disorder. Not much, but the basics of movement disorders will be dealt in detail today. So a little bit about the history, which I would obviously want to focus on the major aspects and the major historic perspectives in movement disorder. The first time in 17th century, Willis was the scientist who actually thought corpus striatum was the seat of motor power, which was later on disregarded. So back then there was no neuroimaging, there was no MRI. The only way to localize and formulate hypothesis was to follow up the patient and do a necropsy and an autopsy, and then only find out the changes of that autopsy changes to the particular disease. So this was later on disproven by this scientist called Vesalius. So he distinguished the fact that cortex is the seat for motor power and the basal ganglion is something else. So the cortex is a major seat for motor cortex. This was later on proved by Vesalius. So in later, after like 200 years in 19th century, then came other scientists called Broadbent and Jackson. Then they actually came up with the hypothesis of striatum being the head of movement disorder, and the origin of movement disorders is primarily being, basal ganglion, that is striatum. Chorea specifically by Broadbent, and acidosis by Hammond. And later on in 1873, Trezor was the first one who described tic disorders. And the Tourette syndrome was described by the name itself, Guillain-Barré, in 1885. In 1950s, you had neuroleptic-induced Parkinsonism was first recognized. Between 1950s and 1960, the first description of hyperreflexia, that is the startle disease, was described. And the latest and the most controversial one is PANDAS. That is, we'll discuss about PANDAS. That is pediatric autoimmune neurological neuropsychiatric manifestations with streptococcal infection. This was first described in 1998 by Dr. Susan. And when it comes to the surgical aspect, Benebit was a scientist who accidentally discovered deep brain stimulation while performing a surgery in a patient with Parkinson's. So he accidentally injected this probe with electric current into the patient's thalamus, and he saw that the tremors of that patient, which were intense, have decreased and even stopped. So that is when the concept of deep brain stimulation in the concept of tremors in Parkinson's was initiated. So this was indeed a serendipity, that is a discovery by accident. And in 1971, then there came a concept of baclofen intrathecal injection for severe movement disorders. And after millennials, after 2000, we all are well aware that, genetics came into power, and next generation sequencing and precision medicine became very, very advanced in late 2010 and 2015. We have a lot of genetic dystonias and specific medicines being used now. So that is about the quick history. So broadly dividing, movement disorders in children can be divided into hyperkinetic, that is hyper, that is more, and hypokinetic disorders. So hypokinetic disorders are not that common in children. They're more common in adults. So here you have bradykinesia, hypokinesia, rigidity, freezing, and stiff muscles. We don't see that very often in the pediatric practice, but most of the pediatric practice revolves around your hyperkinetic movement disorder. So hyperkinetic movement disorders can be divided into rhythmic and non-rhythmic. So when it's rhythmic, it's tremor, and non-rhythmic, you have a few type of variations wherein you have it's a non-rhythmic sustained movement and a twisting posture-like movement, that is dystonia, and it's non-rhythmic slow and snake-like movements, it's called ectosis, and non-rhythmic fast movements can be tics, asterixis, balismus, chorea, dyskinesia, and myoclonus. We'll discuss these movement disorders in detail. But try and understand the basic principle and the basic description of this movement disorder. Tics are basically stereotype, intermittent, sudden, and repetitive movements, and you have the urge to do it. Sometimes you can suppress it. Stereotypes are pretty similar to tics, pattern, episodic, repetitive movement disorder, but usually stereotypes are associated with some sort of underlying neurological disorder like global developmental delay, autism spectrum disorder, ADHD, etc. Chorea, as I said, it's a semi-purposive or quasi-purposive movement which happens more prominently in the proximal joints, both in the upper limbs and lower limbs. You have chaotic movements which are sometimes snake-like and sometimes can be associated with athetosis. So these are involuntary, but to some extent, they can try to suppress it, but they won't be able to do that all the time. So we'll also see a few videos of chorea as well. Dystonia is a very common movement disorder which we see in our pediatric practice. It's repetitive, sustained abnormal twisting posture of a muscle or a joint across a movement. And the twisting quality is always the most characteristic feature of dystonia. And it's intermittent, quite often stimulated by pain, painful stimulus, and usually disappears in sleep. Myoclonus can be epileptic and non-epileptic. In the movement disorder, we read about non-epileptic myoclonus as sudden shock-like movements, which you see is called myoclonic movement or a myoclonic jerk. Tremor, as I said, it's a rhythmic oscillation around a central point. You'll be able to easily see the frequency or the rhythmicity of that oscillation will be quite similar. So that is tremor. And as I said, hypokinetic movement disorder will be Parkinson's. It's a combination of resting tremor, slow movements, bradykinesia, hypokinesia, and rigidity. So we'll not see this common in pediatric practice, but we also see prototype disorders in our coming slides. So what are the common challenges we face as pediatricians and also practitioners in diagnosing movement disorder? First is the range of symptoms is very, very extensive. It's not humanly possible to know each and every movement disorder in extreme detail. For the general pediatrician to know this, it's going to be really, really difficult because you'll be seeing a lot of other patients as well. But the next complexity is, movement disorder is often associated with another associated manifestation like comorbidities. It becomes extremely complicated. And there is no lack of clear diagnostic criteria in which type of movement disorder you want to classify this particular thing in. So we don't have a consensus or a diagnostic criteria that makes it even more confusing and gray. And this can be a little subjective, but pediatric residency doesn't primarily train on pediatric movement disorder like in adults. The movement disorders are very well trained because they see a lot of Parkinson's and hypokinetic movement disorder in children. In pediatric residency, the exposure to movement disorder per se is not that common when compared to adults. And the communication barrier, the movement disorder happens in an adult patient, he is going to describe it very well to you, each and everything, the onset of it, the course of it, and how it ends, what is the frequency, everything can be easily known. So, but when it comes to pediatric practice, then the communication barrier, the child is not able to tell everything. So that is a major challenge in pediatric practice. And often the child is already on so many medication by the time the child visits you for the first time. So that often changes the phenomenology of that movement disorder. So the term we use semiology for seizures, we use phenomenology for movement disorder. That is the way you describe the movement disorder. How are you explaining that is basically called phenomenology. So often, even before you know what is a movement disorder, even before you diagnose what is the etiology of it, a lot of people start a lot of medications like clonazepam, trihexyphenidyl, and often that movement disorder is suppressed and that changes to a milder variant. So quite often, children come to us when we see specialists. They're already on too many medications, so we have to see the first video of that child who had the home videos preferably. And as I said, started on medications without adequate etiological workup again. So treating a movement disorder basically is not symptomatic treatment. You have to find out why this movement disorder started. You have to go right into the basics and etiology. You need to dig up the etiology. As I said, a systematic approach is very extremely important. Home videos are the most crucial in seizures and also movement disorder. And the background history, I would not go into the details. Extremely important. Everything is important. Perinatal, developmental, family history, medication history. All of them are equally important in a movement disorder. And onset is very crucial. Like acute onset movement disorder, think about drug ingestion or a tardive dyskinesia or any sort of poisonings. Subacute onset, you start thinking about other causes like autoimmune encephalitis, chronic can also autoimmune encephalitis and SSP and other so chronic is going to be tick disorder. So based on the onset also we'll also have a diagnostic clue. And the most important thing is the movement disorder, is it associated with any other neurological manifestations like neuropsychiatric manifestations, seizures, associated developmental delay. All these are going to be extremely important. And a thorough clinical examination will never be skipped in any movement disorder like any other neurological case. A thorough clinical examination And especially here, I'm focusing on few provocation maneuvers, which we are not routinely done in neurological examination, but certain maneuvers can actually exaggerate movement disorder. So you need to do that, like outstretching your arms. For example, if a child has chorea, he'll not be able to clearly see the coriform movements. When you ask the child to outstretch the arms, and you can easily see the coriform movement which can be seen. That is one example. And also rational investigations in movement disorders, like you need to do imaging. You try to see any structural malformations or structural defects or structural abnormalities in basal ganglion. You do an MRI, and then if you're suspecting it's a primary genetic disorder, you can also go for whole exome sequencing. So another complexity is that movement disorders are often mixed in children. If you see this diagram, Parkinsonism has a very close overlap with dystonia. Chorea has a very close overlap with acidosis. Ataxia has a very close association with dystonia. So all these movement disorders are often mixed, and you need to find out what is the predominant movement disorder. And on the other hand, movement disorders are very easily confused with epilepsy. So this is another confusion. So if you see here, epilepsy mimics are actually the movement disorders or the movements which look like epilepsy, but they are not epilepsy. And sometimes borderline is basically the child may have epilepsy, but sometimes a child with epilepsy can also have non-epileptic events. So that is borderline. And epilepsy is this category is a true epilepsy patients. And what I'm trying to focus is epilepsy chameleon. So this is also very important. They're actually true epilepsies, but they don't look like epilepsy. So this is also very important that you miss an epilepsy and you say that it's a movement disorder. This child is going to have a big seizure later on, land up with status epilepticus. So that is also a problem. Either ways, it's going to be a problem. So an example for epileptic chameleon would be, a few epilepsies like G1 syndrome. G1 syndrome is eyelid myoclonia, wherein eyelid myoclonia is commonly misdiagnosed as tics, and sometimes they can land up in GTCS later on. And so these are, and absence seizures also very commonly misdiagnosed as daytime and staring episodes. They are also very closely, and infantile spasms are often misdiagnosed as abdominal colic and infantile myoclonus, etc. So these are few things which you must remember, that movement disorder is a diagnosis. Definitely, you have to make the etiology, but at the same time, do not confuse a seizure to be a movement disorder, because that is also going to have very bad consequences. So the systematic approach, as I said, is that first try to define, is it truly a movement disorder or not? Second, classify the movement disorders and which is the predominant movement disorder. And then, for example, the child has myoclonus and dystonia. Try to see which one you want to focus. Is it dystonia predominant or myoclonus predominant? Third, then question yourself that is this movement disorder functional or not? Because functional movement disorders are very common. And then try to understand the clinical syndrome. For example, there is a perioral dyskinesia or orofacial dyskinesia, along with subacute onset of behavioral problems. Then you try to think that this sort of movement disorder can be part of autoimmune encephalitis. So try to put it in a clinical setup and identify the clinical syndrome. And then later on question, the acute causes are ruled out, like autoimmune encephalitis is ruled out, the neuroimaging is ruled out. Structurally, basically, it looks normal. Then you start thinking also about two other things, that is acquired causes and genetic causes. So before thinking genetic, also think of the acquired causes, like, as I said, SLE, lupus, SSP, Wilson's disease. All these are treatable causes of movement disorder, very commonly presenting in children. So start thinking of acquired disorders, and also try to see if this movement disorder can fit into treatable inborn error metabolism. So as this is extremely important in children less than 2 years, because most of the inborn errors of metabolism affecting the basal ganglion usually present in the first 2 years, that is small molecules. But sometimes you have some inborn errors of metabolism like NBI spectrum, Wilson, they can also present later on. So try to fit it in a treatable inborn error disorder. And then later on consider genetic testing for primary genetic dystonias. So after genetic testing, you can also phenotype this particular movement disorder into particular gene, and then you can also think about precision medicine in this. So these are a few important MRI features in predominant movement disorder phenotypes. For example, if you have a child coming to you with movement disorder, the first thing you think about is Wilson's disease, because Wilson's disease can present in any way, but predominant movement disorder is also very common presentation. So MRI is going to reveal a lot of changes in the putamen, and that is going to be a diagnostic feature. And then you can go for a KF ring and then genetic testing. In the same way, iron deposits is a very characteristic feature of NBI, especially PCAN, INAD. In children, MPAN, BPAN can also present. So you have iron deposits shown as T2 hypointensities. So depending on these various typical MRI features that also give a clue for etiological diagnosis of the movement disorder. So based on the type of movement disorder also, you can also have etiological clues. For example, dystonia localizes to your basal ganglion. It's pretty commonly seen in thalamic and basal ganglion involvement, like mitochondrial cytopathies, Aicardi-Goutieres syndrome, neurotransmitter disorders. So they can have predominant dystonia. And in mitochondrial disorders, you can have myoclonus and Parkinson's, as I said, in there are few causes of Parkinson's in children. So whenever you have a child with Parkinsonism like features or hypokinesia, bradykinesia, start thinking about Wilson's disease in the first go. Followed by mitochondrial disorders and followed by NBI spectrum. They can also present with Parkinsonism. So I'll not go into the details of the entire neuronal network of movement disorder, but the major game players in the movement disorder are going to be your basal ganglion, and they have various communications from thalamus, premotor cortex, brainstem, and spinal cord. So this is the major center for the movement disorder, that is the basal ganglion. That includes your caudate nucleus, putamen, GP, substantia nigra, and subthalamic body of nucleus. They have a complex network. They have communications coming from premotor cortex. They have communications coming from motor thalamus, and they also have few fibers coming from up and down from brainstem and cerebellum. So in these neuronal networks, you have inhibitory pathways and excitatory pathways. So based on the predominant neurotransmitter, glutamate or GABA, it depends which is the inhibitory pathway and which is the stimulatory pathway. So this is a complex interplay which happens in the complex communication between these parts actually give rise to, or the pathology gives rise to a movement disorder. So we are going to see a lot of videos now. So kindly not take videos of this because a lot of consents have been obtained for the videos, but this is for the research and scientific sharing, but some of them have not agreed for a large gathering videos like this. So I think we'll just see few videos and I'll just give you 10 seconds to identify the movement disorder and then we'll discuss about this. So this is a child who's come with 8 days history of these movements, and the child is around 7 months. The child frequently does this whenever the child is excited. So you see I'll play this video again. The child has shaking like movements of the lips and face, and also movement of the upper limbs also sometimes. This happens very often when the child is excited. So this is a very typical movement disorder, which is benign, which is called shuddering. So shuddering is a very benign movement disorder, doesn't need any treatment. All you have to do is reassurance to the parents. Shuddering literally means shaking. So it's a type of behavioral disorder or movement disorder in children, which doesn't need any specific treatment. So it goes away with age progresses. This is the second video. This is a child around 11 months of age. On examination, this child had noise-induced sudden jerk-like movements. And also when you tap on the glabella, the child has a myoclonic jerk-like activity, like sudden shock-like activity. So can anybody guess what is this video focusing on? So this is one of the startle syndromes. This is called hyperreflexia. So these multiple movements can be there, multiple events can be there in a single day, and they are sudden, excessive, jerky-like movements which are stimulated by sound or to glabellar taps. So typically, a genetic disorder which is called hyperreflexia, and it happens because of the genetic difference in glycine receptors. And there's a maneuver which can decrease the frequency of this maneuver, these movements, which is called Vigevano maneuver, where you flex the thighs and they dramatically respond to clonazepam because clonazepam primarily acts on glycine receptor. So this is hyperreflexia. Okay, another child, 7-month-old female child, came to history of these movements since last 3 weeks. Okay, these movements happen the entire day and they tend to come down in sleep. So along with this, the child also had developmental arrest and regression. So this is, can anybody identify what is this type of the movement disorder? What you see, this is infantile tremor syndrome. So infantile tremor syndrome actually can be associated with other findings like the signs of vitamin B12 deficiency, hyperpigmented hair, knuckle pigmentation, and also developmental iris. And sometimes, you can also have seizures and other association and complications as well. So this needs to be suspected and diagnosed on time so that it can be treated with vitamin B12 and other micronutrients. Another child of infantile tremor syndrome can clearly see there is tremor, perioral tremor, there's tremor in the extremities, and also see this child is a little plump and has knuckle pigmentation if you see closely. There's tongue tremor as well. You notice this child had knuckle pigmentation also. So this is a typical child with vitamin B12 deficiency. So this is another child who has come, 6-year-old girl came with history of these movements since last one day. The child is conscious, she's not confused. The sensorium is fine, but the child is not able to move her neck freely. So there's stiffness across the entire spine and neck. So on the first go, I think you need to start thinking of neck stiffness as a part of meningitis. But this child did not have any history of fever. There's no history of any altered sensorium. Everything else was normal. So there was a clue in the history. This child was not vaccinated fully. So this is a log-like rigidity, what you see in tetanus. So the same picture can also be seen in few poisonings like strychnine poisoning. But when you have like sudden onset or subacute onset stiffness of the entire body, you can think of tetanus in the background of an Indian setup where the child is not vaccinated, and the history of injury may not be always remembered by the parents. Okay, there are a few more videos now. We'll just quickly go. The first video, this child has eye blinking like movements. So these are tics. This is another video who has eye blinking only on the one side. When you start taking the video, they do it more frequently. They don't have any other movement disorder. So these are also tics. So on the contrary, I'm also playing another video. On the third video, you see this child. This child has very rapid, jerky movements of hemifacial movements. See this deviation of angle of mouth, this twitching of the left eye, both the eyes. So this is not tics. This is a typical focal event seizure. So I'm putting them both together because you need to differentiate an epileptic and a non-epileptic movement disorder. I mean, you have to differentiate a seizure and a benign movement disorder. So these are tics which don't need any treatment per se. They are not very severe, so you don't have to treat. On the other hand, this cannot be disregarded as a movement disorder. This is a frank seizure, a focal seizure. Okay, so a little bit about the tic disorders. When the tic disorders are diagnosed, you have to keep in the mind of the duration. So if the tic disorder is persistent beyond 1 year, then only you say that it's a chronic tic disorder. If the duration of that tics is less than 1 year, you think it is a provisional tic disorder or the transient tic disorder. And when you have tic disorder with predominant motor and vocal tics, so the combination of motor and phonic tics lasting for more than 1 year. So this classifies into the criteria of Tourette syndrome. So you need to find what type of the tic is it. Is it predominantly vocal, or is it predominantly motor, or is it a combination of it and the duration? So based on that, you can classify. So nobody exactly knows why tics happen, but there's a lot of hypotheses which say that the major tic generation which happens in the motor cortex, in the primary motor cortex, and the frontal lobe helps in the tic suppression. So the complex interplay between this, there's some dysregulation between these tic suppression areas and tic generation areas, so that can actually have tics. So as the movie Hichki goes, Rani Mukherjee has this condition where you have both motor and vocal tics. So she had a classical Tourette syndrome. Okay, let's go into the next case. So this is a child who is around 9 years old, came with these movements. Since last 2 weeks, the child was taken to a temple thinking it was a demonic possession, and then later on came to the OPD for further processing. So this child has these movements continuously throughout the day. You see, how do you describe these movements? So there's proximal, there's also few distal, semi-purposive, involuntary movements involving both upper limbs, lower limbs, face, and also perioral twitching. So this is a very classical movement disorder which can be described as chorea. She has a very classical choreiform movements. So in India, whenever you have a child with chorea, start thinking about Sydenham's chorea unless and until you prove it otherwise. And this child also had arthritis 2 months back. And also on echocardiography, this child had mitral valvulitis. So this was a classical case of Sydenham's chorea with acute traumatic fever. So here in this CVC, there's involuntary semi-purposive twisting like movements and proximal movements in the right limb, lower limb, and also in the left limb. She's trying to cover it up with, she's trying to hold her legs, she's trying to hold her clothes, she's trying to, set her hair. She's trying to cover up the movement, but she's unable to do it because the movement disorder, the chorea is so prominent. Okay, so this was the case of Sydenham's chorea. This was after the treatment. We gave her pulse steroids and haloperidol. The movement disorder significantly improved, though she has very mild movements, but to a greater extent, she has improved. So this is one of the provocation maneuver wherein you want to see prominent coriform movements. So apart from the movement disorders, we have discussed Sydenham's chorea. We have to discuss about pandas and PANS also. Pandas is basically pediatric autoimmune neuropsychiatric manifestations which are associated with streptococcal infection. Another controversial topic wherein half of the world thinks that this disease doesn't exist, and this is a diagnosis of exclusion, and half of the world thinks actually this exists. So this is a complex disorder when it's an immune-mediated phenomenon. Following the infection of streptococcus, you have antibodies against the neuronal antibodies which act against various body parts. I mean, various parts of your brain like basal ganglion and also cortex. They cause a lot of range of problems in neurology. Like if you see, start with the typical description is OCD, tics, and it can have rapid changes in behavior, psychosis, sleep disturbances, dysuria, emotional lability, depression. So all this is a very huge range of symptoms which can happen in pandas. And when you see PANS is basically pediatric autoimmune disorder, neuropsychiatric disorder with not associated with any streptococcal infection. So this can be because of other infections like post-infections or viral. They can also have similar pathogenesis. But again, as I said, this should be a diagnosis of exclusion or a very rare or a controversial topic. We'll say few more disorders. One, this is a child who has a developmental delay in these movements. So these are typically described as the stereotypies. So they are non-epileptic, they are rhythmic to some extent, and they're repetitive, they're patterned. On the other hand, this is called the head rocking type of stereotypy, and this is called the body rocking type of stereotypy. So this is the second video. The child has autism spectrum disorder with this type of movement, wherein he tries to constantly rock his body up and down. So this is a body rocking type of stereotyping, very commonly seen in autism spectrum and other developmental disorders. I'll just play the video. All right. So he has head rocking, he has also body rocking. So these are stereotypies. So what are stereotypies? Basically, stereotypies are repetitive pattern type of movement disorder which are not epileptic. They cannot be classified into tics. So there are various type of stereotypes like shaking, hand shaking, body rocking, hitting himself like head banging, head rocking. So all these are various type of stereotypes which can be seen in other neurodevelopmental disorders like autism spectrum, ADHD, GDD, and few genetic disorders. So you need to differentiate stereotypic movement to a non-stereotypic movements like tics or dystonia or a frank seizure, because stereotypes do not need any active management. So this is a child with a diagnosed with a genetic diagnosis of Rett syndrome. So if you see the chest, this child has midline stereotypes. The hands are constantly in the center. The child also has some random repetitive lip movements. There is facial dystonia. There's also midline movements in the hands. So the midline stereotypes are very characteristic of Rett syndrome. So this was a genetically diagnosed case of MECP2. And they have a range of movement disorder in Rett syndrome, like ranging from hemifacial dystonia. They have seen this in the first go, I thought it was a focal seizure, but we did a video AG and this movement did not have any ictal correlate. So this was a movement disorder which was seen in Rett syndrome. So Rett syndrome, remember, they have a range of movement. It's a very florid movement disorder, which can range from dystonia, hemifacial dystonia, midline stereotypes as well. So this video actually focuses on the hemifacial dystonia and also the midline stereotypes. This was another child who came to our ICU with, she's a 14-year-old female who has come with history of these movements since last one day. overnight she developed these movements wherein she's completely stiff, the entire body, and she is arching up. See, she even had one episode of like opistotonic posturing. So this child ended up having Wilson's disease. So whenever a child comes to you with movement disorder, acute onset movement disorder, start thinking about drug ingestion. Then we have think of poisonings, and then also think about other common genetic disorders which can affect your basal ganglion. That the first in the order should be your Wilson's disease. In the second video, this child has just try to identify the movement disorder. This child has this twisting type of movements of the legs, this crossing over of the legs, and this the upper limb is also like going with dystonic posturing. So this is a typical dystonia, what you see in an infant. So this child, if you see, there's also facial puffiness. So this child had cardiomyopathy and dystonia. So whenever you have cardiomyopathy and dystonia, start thinking about this entity called biotin thiamine responsive basal ganglion disease. On MRI, this child had typical hyperintensities and diffusion restriction in the bilateral thalami and bilateral, caudate nucleus and lentiform nucleus. So this happens because of maternal deficiency of biotin and thiamine, and this lack of biotin and thiamine in the mother's milk in the first 1 year of life. A very common entity in India. Coming to our next video, here this child has presented with history. He's a 14-year-old child. He has come with history around 2 weeks of emotional lability. He started crying in the school and also has sudden change of voice and also sudden change of facial expression and also movement disorder. So you see, this child is not able to talk properly. His voice is not clear. And also, if you see when you ask the child to smile, this child has a sort of grin or a deviation of face to one side. So is some amount of facial dystonia or hemifacial dystonia, along with this subtle grin, which is called rhizus sardonicus. So rhizus sardonicus in a pediatric neurology practice is very much specific to few disorders. And whenever you start thinking about rhizus sardonicus, the grin like smile, what you see, you start thinking of Wilson's in the very first scope. So Wilson's disease can present with a range of disorders and range of manifestations, ranging from movement disorder, behavioral problems. This child had both behavioral and movement disorder. This child also had KF ring positive, and this child did not have any liver involvement. So this was a genetically proven case of Wilson's disease. So in the same context, I would also like to discuss about this range of movement disorder, which can happen in this spectrum of neurological disorder, which is called NBIA. This is neuronal brain iron accumulation. Slide 20. Okay, yeah, got it. So this can happen because of the iron deposition in the brain. So there are different types of NBI spectrum which can see, ranging from PCAN, INAD, MPAN, BPAN. And the common ones in children are INAD, BPAN, and MPAN. PCAN starts a little later on, and neuroferritinopathy, Woodhouse-Sakati, and Kupffer-Jacob start very late in the age, that is over 40 and 50 years. So they have predominant movement disorder. On the right, if you see the picture of this old lady is completely bent from the spine. This is called camptocormia, wherein the person is completely bent like a worm. So this is called camptocormia. It's a very florid movement disorder. So this is another child on the left. If you see, this child has complete opistotonic posturing. This is because of status dystonicus. This child has molybdenum cofactor deficiency. So status dystonicus is a medical emergency. You start treating them very aggressively and preferably in an ICU, because status dystonicus can cause a lot of other consequences like rhabdomyolysis and even sometimes fractures and CKD because of rhabdomyolysis and all the other complications of status dystonicus. So you need to you need to treat them very aggressively with injectable anti-dystonia medications like benzodiazepine, and then you can also consider intrathecal baclofen, deep brain stimulation, and also paralytics. So this, I'll just skip. So this is a child who has come with a history of these movements since last 6 months, a 12-year-old child. If you see, this child try to identify the movement disorder in this patient. We'll play the video again, second video as well. So this child had these movements throughout the day, but when he's sleeping, he's going to be completely normal. So he has some sort of dystonic movements. Now, if you see on the left and right side, there's alternating posturing, and this typical dystonia, proximally more predominant, and also there is hemifacial or neck cervical dystonia. So along with few components of myoclonus as well. So this is typical dystonia description, and the onset being since last few months, 6 months, you can start thinking about it's a genetic dystonia. So these are the various types of genetic dystonias. You'll have to now, after the availability of free access to next gen sequencing, in the last 10-20 years, we have new types of dystonias being discovered. The range of dystonias. So whenever you have a family history or you have other causes ruled out, consider next gen sequencing for primary genetic dystonias. So this is the range of genetic disorders with specific treatment also. Like few mutations will respond to few medications properly. For example, PRRT2 mutation can respond very well to carbamazepine and phenytoin. This is one of the example. I'll just skip this video. This is another rare movement disorder where the child has this chin tremor. So this is hereditary chin tremor or geniospasm, a very rare entity. It can have autosomal dominant penetrance it can have families in the parents and grandparents as well. Another interesting case, this was a child of 11-year-old who had this movement disorder since last few months. He has been seeing a lot of dermatologists for pruritus and itch related dermatological conditions. But if you see this closely, this child doesn't primarily have itching. This child also has, whenever he itches, he also has like subtle involuntary movements of the lower limbs as well. So he has some range of coriform movements, but unfortunately, we couldn't evaluate this child further on. Now we'll quickly see a few videos. This is the first video. If you see this child is trying to make some movement wherein it doesn't look like a seizure. It looks asynchronous, asymmetric. Obviously looks like functional. Another video of the same patient. Random movements of both upper limbs, asymmetric, asynchronous. And whenever you start shooting the video, these movements are going to be extreme. He wants hospital admission very commonly. He has a background of disturbance in the family. So all these are very important clues in identifying a functional movement disorder. So this is called functional neurological disorder, functional movement disorder. But at the same time, do not diagnose any child coming to you, any teenager or any female teenager coming to you should not be functional on the first go. You have to rule out all the organic causes. Another functional neurological function FND, that is functional movement disorder. This child has like these sort of spells. And whenever you give him this nasal spray which doesn't contain anything, normal saline, and he becomes okay. So no movement disorder is going to be halted with a normal nasal saline drop. So this is functional movement disorder. Another example of functional movement disorder, she loses her consciousness. She says that she loses her consciousness whenever people are observing her. When you start taking videos, and she's going to do these episodes more commonly. And she doesn't want to go to school as well. So this is a functional movement disorder. Another functional movement disorder, she's around 14 years. She came with acute history of these movements. She has few features of tics, and also she also has few behavioral manifestations. So it doesn't look like seizure per se. But we still evaluated this child for autoimmune encephalitis and other organic causes. It turned out all the investigations came back negative. So this was the primary neuropsychiatric disorder. So this child was started on antipsychotic medications. This was another child who was around 14 years old, came with acute onset history of these movements one day. So he has few movements wherein he's not able to understand where is he exactly, why is this happening to him, and he has tonic posting or dystonic posting of his upper limbs in this video. It looks dazed also, but apparently he doesn't have any history of drug intake or any other family history. And see the second video, this child has the posting of the lower limbs also. Both posting of upper limbs as well as lower limbs. Again, this ended up having, all the investigations being negative. So what is weird about this child also had these movements in the sleep. So that's when we thought it could be probably, organic, but we couldn't find any cause for the movement disorder. And this child eventually responded without any treatment as well. So this is the umbrella of functional neurological disorders. I won't go into the details of it, but There's a whole range of disorders or types of disorders, but do remember functional neurological disorder should not be your first TD. It's a diagnosis of exclusion. And the terms like conversion disorder, hysteria, mass hysteria, psychogenic, medically unexplained symptoms, psychosomatic, and these are the terms which are not used anymore. Whenever you suspect it's functional, call it FND, that is functional neurological disorders, and do not use these terms which are not accepted anymore. But if you're thinking of a functional in FND, you start also thinking about the family setup for abnormal emotional processing, like the predisposing factor or trauma in the family, emotional stimuli, attention, illness exposure. And with these sort of movements, if the child is getting some benefit or attention, extra attention, so that also needs to be seen. That is secondary gain. So all that needs to be seen in FND. Just skip this video. So this is another child who had these sort of movements. I posted this video because this is a frank seizure. If you see, this is a myoclonic seizure and not a movement disorder. So you need to be very careful not to diagnose a movement disorder and miss a seizure, frank seizure. So this is a frank myoclonic seizure. This child had genetic myoclonic epilepsy. Another movement wherein you see this child has come with the history of seizure on tapping on the jaw in the region of facial region. This child had twitching movement. So this is not a proper movement disorder, but we need to rule out all these conditions. Like, this happens in hypocalcemia. This is Chostek's sign. Oh, this is an interesting one. This is a 16-year-old female who came with 2 weeks history of behavioral problems, emotional lability. She cries excessively and also has this movement and movement disorder, wherein she slows down. And if you twist her face to one side, and she'll stick to that place. You see the hand movement as well. So he's trying to fixate that particular joint in that position, and she keeps to in the same position involuntarily. So this is called waxy flexibility or catatonia, a very rare phenomenon. Catatonia is a condition wherein you have different type of manifestations, but waxy flexibility is one of the characteristic features of catatonia. And whenever you have a child with catatonia, start thinking about both organic and functional causes. So you have to rule out organic causes like autoimmune encephalitis, metabolic disorders, nutritional deficiencies. And if everything is negative, then think about primary psychiatric disorder, because schizophrenia is a very common cause of catatonia. But this child has NMDA receptor antibody encephalitis. So this child responded very dramatically to pulse steroids. So a little bit about NMDA receptor encephalitis. It's very extremely important in pediatric practice. Any subacute to chronic disease presenting with history of psychiatric manifestations like paranoia, social withdrawal, decreased scholastic performance, anxiety, emotional lability, and then later on presenting with movement disorder and epilepsy, you start thinking about autoimmune encephalitis, predominantly NMDA being the most common in children. So it's a treatable condition. So whenever you suspect this, and you have to test for CSF antibodies and treat steroids. On the right side, if you see, movement disorder in NMDA can have a very florid orofacial dyskinesia. So orofacial dyskinesia is like puckering, mouth puckering, tongue thrusting, or twisting postures of your face and facial angle of mouth. So all these can happen in the orofacial dyskinesia spectrum. So very characteristic feature of NMDA receptors. So this child also has this tongue protruding type of movement disorder. So we couldn't definitely identify this type of why this has happened, but this tongue protrusion is also a classical description in tardive dyskinesia. So if you see, the meaning of tardive dyskinesia is basically delayed onset of symptoms. That is, if the drug was given today, for example, if the patient is exposed to metoclopramide today, so the movement disorder can happen after a few weeks and can persist for a few weeks even after the stoppage of metoclopramide. So that is the meaning of tardive dyskinesia. So delayed onset can happen because of some idiosyncratic reaction of that particular drug, and why that movement disorder happens, nobody knows, but it is purely drug induced. Once the drug is stopped, that the frequency and severity of that movement disorder can come down. So in the range of tardive dyskinesia, you can have tongue protrusion, lip smacking, mouth puckering, facial grimacing, excessive eye blinking, and writhing-like movements, and also pelvic thrusting movements. All these can be a spectrum of tardive dyskinesia. And the common culprits here are metoclopramide and the typical antipsychotic medications. Like, the first generation antipsychotic medications can are very known to cause haloperidol, fluphenazole, are very known to cause tardive dyskinesia. And a few more videos. This is a child with erratic myoclonus. If you see the random movements of hands and legs, along with this child also has erratic movements of the eyeball as well. Not very clearly seen in the video. Whenever you have erratic myoclonus and eye movements, start thinking about obsoclonus myoclonus syndrome. Another similar patient who has come with these eye movements since last few weeks. We see this is the typical random chaotic movements of the eyeballs. This is called obsoclonus. So whenever you have obsoclonus, start looking for myoclonus and ataxia, because the syndrome is obsoclonus, myoclonus, ataxia syndrome. All three can come in different orders. So if you have one, look for the other, because they're very, very treatable. Because when you have OMAS, that is obsoclonus myoclonus syndrome, you start looking for underlying occult neuroblastoma. And the treatment would be then to take off the neuroblastoma and then give steroids. And they have to be a very aggressive immunotherapy, steroids plus ACTS, even for even IVIG as well. Some people even give rituximab based on what guideline are you following. So this is one of the movement disorder in a child with a suspected neurometabolic disorder. If you see, there is choreoathetotic movements. It's very beautifully seen in this video. There's random involuntary distal as well as proximal, like slowing movements, which can be seen. Both a combination of choreo and athetosis can be seen. Very quickly about the treatment here. In hyperkinetic movement disorders like chorea, athetosis, dystonia, tremor, we use the drug based on the type of movement disorder and also the probable etiology. In chorea, we tend to use haloperidol in Sydenham's chorea, valproate, carbamazepine. Dystonia, we start on medications with gabapentin, trihexyphenidyl, baclofen. And if it's dopa responsive dystonia, we start giving dopa. And if the dystonia is not responding, then we go for the next line of treatments like intrathecal baclofen, and then go for DBS, that is deep brain stimulation. When it comes to tremor, the first line of drug should be your propranolol, and topiramate K is also a good drug in tremor. And tics per se, the tics we prefer using tetrabenazine, risperidone, and clonidine. Clonidine has the best efficacy, followed by risperidone and tetrabenazine. So these are few drugs which are specifically, you need to choose the right type of drug for the right movement disorder. So that is how it works. I won't go into the details of these movement disorder because the surgical management of these disorders, but deep brain stimulation can be considered for any movement disorder which is refractory. So this is available in many centers in India as well. So I'll just summarize everything. A quick take home. Movement disorders in children are very complex. You have to have regular follow-ups. You have to see this video, ask the parents to get more and more home videos, and to take the repeated history and try to identify what is the type of phenomenology. Try to describe what is a movement disorder. Just plain simple dystonia, chorea, whatever it is. Then later on try to dig up the etiology. Second, the onset of illness is extremely important. That is acute versus subacute versus chronic. Acute will be in the first 1 week or few days. Subacute will be few days to weeks, and chronic will be like usually weeks to months. So the etiological clue comes from this particular, the history. As I said earlier, acute we start thinking about drug addiction, tardive dyskinesia. Subacute and chronic start thinking about SSP, Wilson's, and other genetic disorders. And also see whether this movement disorder is transient or intermittent or progressive. So progressive usually needs evaluation, but intermittent you can wait, but transient you don't have to always wait, because sometimes evaluating a transient movement disorder may not always yield up to etiology. And also look for associated manifestations like neuropsychiatric manifestations, seizures, myoclonic jerks, regression. Very often, movement disorder strikes. Very often, it can happen that movement disorder is with something else which is also prominent, and very rarely it happens that movement disorder strikes alone. So, for example, the typical example of SSP or Wilson's disorder, Wilson's disease, you have movement disorder. We also have behavioral problems like cognitive decline, neuropsychiatric manifestations, and other associated features. Always focus on other associated features, and it should be a complete history. As I said, family history is important here in primary genetic dystonias, autosomal dominant inheritance, mitochondrial disorders and neurometabolic disorders, autosomal recessive, Wilson's, autosomal recessive again, NBI, most of them autosomal recessive or dominant. The family history plays a very crucial role in etiology. And the history of drug intake, as I said, the top culprits will be antipsychotics, that is first generation antipsychotics, and antiemetics like metoclopramide. And few recreational drug use needs to be considered in any teenage boy with history of party or any drug addiction. You have to think about recreational drug abuse and send tox screen. And subtype the movement disorder, is it hyper or hypo? Chorea or acidosis, dystonia, tremor, or whatever it is. Try to subtype the movement disorder based on the phenomenology and then later on come to the etiology. Then the rational investigations I was talking about, neuroimaging, CSF autoimmune panel versus genetics needs to be done based on the case basis. And functional neurological disorders, primary psychiatric disorders, and pandas should always be, down the list of your differential diagnosis. They should be usually be diagnosis of exclusion. And rational use of medications, as I said, clonidine works very well for tics post-extubation. So a whole range of movement disorders can happen in ICU post-extubation. So clonidine is an excellent drug for all sort of ICU movement disorders and tics as well. Gabapentin have extremely good drug for dystonia in more than 2 years. Korea, different people prefer different drugs. In Korea, valproate, topiramate, or haloperidol can be used, and propranolol in tremor. And also, finally, never miss a movement disorder, which is a part of a systemic neurological disorder, which is treatable. For example, autoimmune encephalitis, Wilson's disease, SSP, Sydenham's chorea, obsoclonus myoclonus ataxia syndrome, and tardive dyskinesia is one treatment. So all these are treatable neurological disorders which present with movement disorders. You should never miss these conditions. And I think I'll end this topic with us. Thank you.